Welcome to Health or Consequences, Commonwealth Beacon's podcast devoted to healthcare and public health issues. I'm Paul Hattis from the Lown Institute, here with my colleague John McDonough from the T.H. Chan Harvard School of Public Health. We so much welcome today's very special interview with our new Health and Human Services Secretary in our state, Dr. Kiame Mahaniah. But it's also, I want to say a word before we get started with the interview, it's also a special month for Commonwealth Beacon in the healthcare arena because it's devoting a fair amount of its web space to healthcare issues on the opinion and news side, especially around healthcare access. It's also inviting readers and or listeners to write in about their access challenges, and some of that's being then reposted in a summary way on the website. We also have the special aspect that both Dr. Mahaniah will be with colleagues Manny Lopes from CEO of Fallon Healthcare and John Hurst, the retailers, in person with my colleague John McDonough for a moderated discussion on September 30th at 8:15 a.m. at the Nonprofit Center at 89 South Street, Boston. So for our listeners, we hope not only will you enjoy today's interview, but you'll have an opportunity to see Dr. Mahaniah and John and others in person if you want September 30th. We all look forward to that. But first, Dr. Mahaniah, Secretary Mahaniah, we want to welcome you to our discussion interview today, and really appreciate your being here.
Oh, it's my pleasure, and I recognize the pain of the titles. My wife really liked it when I was undersecretary because she just called me Dr. Underpants, and that sort of worked to cover all bases. And now she hasn't found a new title for me yet.
Well, we'll work our best, and maybe our listeners will have one for you after today's discussion. But we appreciate your joining us, and just so our listeners understand, we know that you've been Secretary of Health and Human Services for a couple months now, when your predecessor, Kate Walsh, stepped back from that position. Governor Healy then appointed you the secretary. And as you noted, moving in from that role as the undersecretary, you really have an interesting background coming into government. And I wonder if you can start the podcast today by sharing some of that with our listeners.
Yes, so for the listeners who unlikely don't know my background, I'm trained as a family physician and did my training at University of Pittsburgh, and moved to the Boston area after fulfilling my National Service Corps obligations. For those who don't know, it's a federal program where they pay for you to go to medical school, and in return, you go work to an area that they ascribe to you. So I did that for 3 years in Pittsburgh. And then I came to the Boston area because my wife is German, and it's the closest actually mainland American airport to Germany. With a direct line is Boston. So we ended up here. And then I really grew up in the health center world. So I ended up doing my duty to the federal government in a health center, and that got me to love the health center world. And so I moved in 2003, and I worked at the Greater Lawrence Family Health Center for a decade. And then I moved to the North Shore and ended up at the Lynn Community Health Center, where I served as CEO for 6 years. And during that time, I got my MBA because the board didn't quite trust that a bleeding heart physician would have all the the knowledge that is necessary. So I got my MBA from UMass Amherst. And then I was appointed undersecretary 2.5 years ago. And as you mentioned, I served under Kate Walsh, learning at her knee, so to speak. And then now, about 6 weeks ago, I became secretary.
So welcome, Mr. Secretary. It's a pleasure and honor to have you with us. And just learning that you went to University of Pittsburgh for your medical residency, I just have to ask, have you seen the TV show Pitt?
I must admit that in my whole life, I have never watched a medical show. Like, it's just too, other than Nurse Jackie. I loved Nurse Jackie, right? So I watched that, especially since, as you may know, I only do addiction medicine these days. And Nurse Jackie was all about, the difficulties of recovery and sobriety and use. But no, so I haven't watched The Pit, but I have not watched any of the other mega the health shows. I just find it a little bit too non-relaxing because I keep critiquing it, and then it feels like work, and then yeah. So I don't. I tend to watch silly shows like Wednesday or science fiction show like The Last of Us. So that tends to be what attracts my attention.
Oh, that's very relaxing. Well, thank you. I'm sorry, I just had to ask. So let's dig into it, and let's start with the major question on so many people's minds, which is the unprecedented, historic cutbacks in federal support for health and medical care in the United States coming from the new Trump administration, and in particular from the July 4th Build One Big Beautiful Bill Act that will, we understand, produce about 3.5 billion in cuts and losses to the Mass Health Program, our Medicaid program, also losses in nutrition assistance, the SNAP program, and many others. I'm just wondering if we can start out by asking you a really tough question. How will the Health and Human Service Secretariat, you and your organization, respond? Absorbing cost cuts, reprioritizing services, pursuing legal remedies? What are you most concerned about, and what are your priorities in terms of dealing with this really awful situation?
Yes. So in terms of the cuts that HR one is bringing up, first, before all your listeners in a panic move to Canada, it is over 10 years. That loss, that projected loss, is over 10 years, and in politics, 10 years is an eternity. So a lot of things can happen between now and 2035 in terms of restoring some of those cuts. But yes, nevertheless, they are significant. Especially, you mentioned the SNAP, the food benefits, which really that effect starts immediately. It started the day after that bill was signed. And in terms of food security, as you're well aware, the governor launched an anti-hunger task force, and the goal is really because the federal government, in terms of the amount of money that they were giving, they were giving something like 90% of all the food that was being sort of used and that people who needed it. And so if 30% of that is going away, it means that whatever we have now that's producing 10% of the food need needs to really scale up. So there's a huge effort to get that going. We will not be able to replace the full amount that we're receiving from the federal government, but we're really hoping to mitigate. On the health side, it is scary, as has been well covered. On January 1st, we already have likely, between 36,000 and 54,000 people who are going to lose coverage because of the changes that are happening. And then over the next few years, we really estimate that the number will climb up to 300,000 in terms of people who will lose access to reliable insurance. Now, on the positive end, we have the health safety net and Mass Limited. So at the very minimum, people have catastrophic coverage, which is always sort of a psychological relief, particularly if you're a parent, to know that even if you don't have insurance, you have coverage for emergency and emergency hospitalizations. But certainly, this is really calling into a question, what are we going to do and how we're going to do it? I think my perspective on it, and I've been talking about this with my team, I've been talking about it with the governor's team, is that we really have to figure out who are the most vulnerable people that we serve, and what are the programs that have the most impact on the people who are most vulnerable. And those programs we have to protect and even enhance at all costs. The reason I'm saying enhanced is that there's so many other things happening in the culture and the economy that are going to put pressure on those very people, right? They're going to be losing housing, they're going to be losing food stamps, they're going to be losing transportation. And it looks more and more like we might be headed towards a recession. So then jobs will be difficult. And so all those things put together means that we really have to be extremely careful in terms of how we prioritize our initiatives and what programs do we decide to scale down or scale back on as we are making sure that we're protecting the most vulnerable. As you know, we don't have that many levers. Now we have changing the rates, which is has been the favorite instrument because you can do it across the field, shared pain. But given how fragile, and you've been covering it in your podcast, given how fragile the healthcare ecosystem is, there's really not that much room to do that without seeing major institutions really suffer. And then you can change eligibility, which is also a very difficult thing when you're thinking about, rationing people instead of rationing money. Or you can think about how are you going to change the way you deliver services so you can deliver it cheaper, or there are some services that you may not be able to deliver in the name of preserving access for other things. So those are the way we're approaching it. But at the lodestar is really how are we going to make sure that this does not fall on the most vulnerable? And that's a challenge. Most systems are not set up to have sort of an ROI on vulnerability. And so we have to set up those systems, and then it has to enter, the sausage making machine of politics because as you know, I don't make the decisions. I come up with options, I offer the options, and then, the legislature makes the decisions. So it is a complex decision, but I must say that I'm realistic that these are going to be very hard years. I'm very realistic about that. But there's also a glimmer of hope that there are things in the system that we do that are not particularly helpful, that don't serve clients particularly well, that we may be able to reform because of this pressure.
So let me just have one brief follow-up on that. So Massachusetts, for the past 6 to 7 years, has operated its mass health program under a massive 1115 waiver from the federal government, where we've set up 17 mass health accountable care organizations and really revolutionized that. That's part of a waiver that I think runs out in 2027. Is there going to be any immediate damage to that? And do you have any sense of whether or not that's something that's also at risk?
No, CMS has made very clear that they're going to let the 1115 waiver process run its course. Partially, it's that if a program is running out in 27, you have to start the negotiations in 26, and 26 is essentially tomorrow. And so we expect that in the negotiation, we'll have to change a number of things. The federal government has made very clear that they take a very traditional, narrow interpretation of what medical care is. And so whether health-related social needs or social determinants of health or whatever it is that you want to call it, they take a dim view of including that in the 1115 waiver. And that was one of the revolutionary things that we did in our waiver. So we're going to have to change some of the language around that. If there's any language that we have in there about supporting pure education that's not medical care, we're going to have to revisit that. And there are a number of programs, for instance, they've said they're really not looking, they really don't read. There are some things that we want to do where essentially you could keep eligibility for a year at a time or 2 years at a time. And they've said that, for instance, our reentry programs coming out of incarcerated settings. And they've said that likely in the future, they may not favor such. So there's some details like that. But you are correct, John, that we are going to resubmit an 1115 waiver. Obviously, there are a number of things in the MAHA agenda that are very palatable to us around chronic disease management and children's health. And so we think that we can craft an 1115 that continues us on our progress, with our wrapping up our progress, and yet would meet federal approval.
Thank you. And let's just switch, if we can, to another area that's gotten a lot of attention, which is the cuts in federal grants, particularly research grants from the National Institutes of Health, from the CDC, and others. How much attention have you been able to pay to that? What are the consequences that you perceive right now that are most harmful to the state from these cuts? And what can the state potentially do to try to mitigate this? Or is this something to be sorted out through the courts?
No, I think I pay very close attention to it. Part of it is that, as you know, we are med and ed state. Like we sort of live and die by our ability to do research, right? That's one of our main pillars. So we're paying very close attention. Obviously there's a limited amount that I can do as secretary for that. And as you know, the governor introduced the DRIVE initiative, which is really an effort to try to preserve the core of the research capability that we have here in Massachusetts. But I would say that the thing that worries me the most, as you know, as a bureaucrat, I think year to year, right? That's sort of like I live in the budget cycle. But what really worries me about the scientific arts is really workforce, because a lot of these grants are things that pay for postgrads to come due. They pay for summer interns. They pay, right? So it's really the workforce of science and research that is going to be coming online in 10, 15, 20 years. That's what I worry about, that these cuts will be dismantling. And so when I'm thinking of where can we intervene, I'm really looking at it with a workforce lens. Is there anything that we can do to help the universities preserve that pipeline for these research scientists, particularly when we talk about people coming from all over the world to Boston, to Massachusetts, in order to work in our science economy. So I worry about it a lot. There's a limited amount that I can do, but I think that as a secretariat, we can have an influence, and we will have an influence.
Okay, thank you. One more federal question, and then I'll hand it over to Paul. So a lot of attention being paid to vaccine policy and public health preparedness. Just noting, Massachusetts is the state where inoculation was first invented in the 1700s, and vaccinations were invented here in the early in the 19th century. And all these changes are coming now from the CDC and the Trump administration around vaccine. What are you most concerned about in terms of the vaccination system in Massachusetts, and what does the state need to do to make sure that there's no significant interruption here?
Yeah, so our wonderful DPH commissioner, Dr. Goldstein, has really laid out a great plan that he and the governor announced last week. I think the way really that Dr. Goldstein has laid it out is the frame that I use. So number one, there's the ability to recommend vaccines. So for that's fairly straightforward. Eventually, most blue states will come up with a single source of recommendations. Most red states will come up with a single source of their recommendations, and most purple states will come up with the purple states will be all variable, but there'll be two big sort of recommendations. So that's easy. I think the harder part is, what's going to happen to the purchasing and the distribution of these vaccines, because that was really coordinated by the CDC, and it was predicated on the CDC covering the vaccines from its own committee. And so will that whole infrastructure go away? Meaning the ability to order vaccines and distribute them. And so that's a big one. Like, we really worry about our ability to buy vaccines, because when the federal government was buying, 360 million doses of a vaccine at one time, they got a certain price that we just can't match as a collaboration of 7 or 8 states. And so we really do worry about the purchase, the distribution, and then, of course, the impact that it could have on health coverage. Obviously, if you are an insurance that's regulated by our state, you will be covering the vaccines that our group will recommend. But as you well know better than I do, something like 40% of the market is self-insured ERISA, escaping state regulation. So we really would have to rely on their own desire to be good citizen, but also save money. Like, it's not in the interest of insurance companies to have flu vaccination rates drop by 10%. Like, that would just explode their inpatient costs, the following year. But nevertheless, there are some limitations. So I worry about purchasing, distribution, and then I worry about insurance coverage for people.
Dr. Mahaniah, let me move you from your really thoughtful and cogent answers to the federal challenges to say that, of course, we have our own state oversight of healthcare issues and challenges. And let's start with one that you have a lot of familiarity with in your own life, which is primary care. And in fact, right now you're co-chairing the newly launched Primary Care Access, Delivery, and Payment Task Force, along with David Seltz from the Health Policy Commission. And like many states, proportionally in a spending sense, we're witnessing a decline actually in primary care spending relative to other kinds of medical care spending, provider burnout issues, and people just being able to find access to primary care. What policy solutions do you envision and concrete steps that we can expect in Massachusetts, perhaps coming out of recommendations from the task force over the next 6 to 18 months?
Yeah, thanks, Paul. And you are quite wise to point out that even if there were no federal issues, we'd still have all these state-based challenges, right, that are particularly onerous to us. I would say that, as the improvement engineers say, you know, your system is designed to get the results that it's getting, right? And I think we have a complex system, but nevertheless, there is a financing system that is not favoring primary care. So all the major stakeholders are really going to have to come together and figure out, okay, what does that mean to change that payment system? Does it mean that we simply go like Washington or Rhode Island, where they just force a certain percentage to be spent in primary care? Or are we going to say, no, we're going to put everybody in a prospective payment that's not fee for service? Or are we going to go to a global capitated budget? There's enough flexibility in there, but we're going to have to move away from the fee for service system in some way, shape, or form, because that just doesn't work. Second, workforce. We have to figure out how we're going to incentivize the desire for people to work in primary care. So, the burnout issue. What are we going to do? Administrative burden. How are we going to use ambient AI to sort of get rid of the pain of documentation and of billing? How are we going to emphasize team-based practice? How are we going to bring up advanced practitioner to the respected level that they should have? How are we going to convince elite academic institutions to be interested in primary care, to have primary care departments within their ranks? So I think all of those things, but I think so all of those things are in play. As you know, the primary care task force will make recommendations. I'm sure we're going to make recommendations around percentage spend in primary care. I'm sure we're going to make recommendation in terms of potential payment systems that we can go to. I'm very sure we're going to make recommendations around workforce. And then I think that you can't do all those things without talking about health equity and how we're going to ensure access to everybody in Massachusetts, and not just those of us who have education and money and privilege. So those are all coming. I'm loath to give you sort of what I think the precise details are going to be, because I actually don't know how the task force is going to turn out. And once we propose those recommendations to the legislature, I don't know which they're going to take. But when I told the governor when I was first appointed, I do think that of all the things that we are considering potential reforms in, I think there's a true appetite among most players for primary care reform.
Fair enough, and appreciate you mentioning healthcare equity. But before we jump into that, I have a sort of a tangent of a primary care question that I think has certainly been on the minds of John and I since we wrote about it recently. But really, it's a project proposal idea that on the access workforce side, that CVS has come forward with Mass General Brigham to convert their MinuteClinic centers into primary care centers and see patients and then connect those patients in as part of the MGB managed care network. Any perspectives you want to share with our listening audience about that particular proposal?
There's lots of. First of all, as a simple business student, I'm sort of intrigued, right? Like, so many people have tried and failed in doing something like that, right? Amazon and Walgreens, and so I'm sort of intrigued to see if the model will work, because those are my friends who are NPs who went to work for CVS, specifically went there because they didn't want to do primary care and chronic disease management. So I don't know how they're going to handle their workforce issues. But let's be honest, right? This is not an ideal way to produce primary care. But we are very far from ideal. And so I think that it's worth supporting the MGB CVS partnership in terms of sort of philosophically. We're not supporting them financially or anything like that. And see, can it put a dent into our issue, even if it were to sort of take away some of the easier primary care visits, which in itself can cause problems, because then what you're left with at health centers and primary care clinic is the very complex patients. And can they figure out how to avoid fragmentation of healthcare and integrate all that healthcare into one? So no, I'm not a huge fan of the prospect, but I do recognize that it could very well serve a need within the market, and it might give us enough time to do what we were talking about before within the primary care. It might give us a little bit of breathing space in order to truly reform the deeper, more fundamental primary care establishment.
Do you worry about any of the potential spending impacts of it, or the fact that these primary care nurse practitioners are not in the sort of milieu you had at the health center where there were physicians around but really on their own? And any thoughts about those two sub-issues at all?
No, I don't think it'll be a quality. I don't think it'll be a quality issue. The nurse practitioners that I've worked with have been fantastic, and they know when to consult and when to send people to the emergency room. No, I'm more worried just that A, it could lead to fragmentation. B, it could be that people think they're getting comprehensive primary care and they're not, because it could be that the culture change will be very difficult for CVS to do, and they may not make that culture change. I worry about nurse practitioners getting siphoned off, especially from health centers. And then I worry that most of these CVS minute clinics are not going to be in gateway cities or underserved areas, right? They're going to be in towns like where I live. And so I worry about accentuating the inequities that we have already in the system.
So we'd like to turn briefly to the important topic of health equity. You are a longtime champion of addressing, and fighting for greater health equity, which for me, equity is just a synonym for fairness. This is featured in your role when you were co-chairing the Advanced Health Equity in Massachusetts effort, and including the Primary Care Task Force. Massachusetts and the nation have been involved in health equity for decades, most recently under the term DEI, diversity, equity, and inclusion. Now in the Trump administration, too, that has become kind of an epithet, a dirty word, something that's not allowed. Organizations, health, education elsewhere are being taken to task and losing funding because of DEI. And so from your perspective, where are we in terms of advancing health equity now in the era of the Trump 2 administration, and with all the open, frontal, blatant attacks on DEI?
I would say that even within the federal government, there seems to be some daylight between what they consider DEI and then what they consider health equity. I think, like you, John, most people think of equity in healthcare more like the way you think of when you're a patient that comes into the hospital. Equity means you go to the level of care that you need, right? Not everybody goes to ICU. Some people just go to give blood at the blood bank, right? And so the way I think of health equity is the capacity of the system to spend more resources and more money on those who need it the most. And even though Trump 2 tries to stay away from the words equity, when they talk about rural health, they're talking about equity. When they're talking about substance use disorder, they're talking about equity. When they're talking about bringing in a digital infrastructure in rural areas, that's digital equity. They're using different words, right? But the concepts, which is that the more pain that you're in, the more services you should receive. I think those are right. Those are accepted concepts, and I don't see us veering away from that in Massachusetts. We may veer away in terms of the rhetorical framework that we use, but I don't see that. Like, if we want to spend more money in behavioral health in Cape Cod or in the Berkshires, I don't see the federal government saying, "Hey, you can't do that because that's equity." They would just be like, "Yeah, go ahead and do that." So yes, I am disheartened by the fact that there's a certain amount of social justice oriented language with which I grew up, which is sort of embedded in me, that I can no longer use. But I'm also recognizing that the crushing majority of the work that we do in the name of equity is really done in the name of fairness, and it knows no race or ethnic boundaries. And I am very confident we'll keep doing it.
Finally, Dr. Mahaniah, and we very much have appreciated your time today. And you come from a background long-standing working in neighborhood health centers who under challenge with the federal government cuts, the challenges around primary care and the like. Anything you want to say about your thoughts or worries or concerns about those kinds of providers going forward in particular?
Yes, I must say I'm very worried. I mean, one of the things that's really shocked me the most since I became undersecretary is the fragility of the whole system, meaning with nursing homes, hospitals, academic medical center, hospital systems, health plans, which nobody feels sympathetic to, but they're also suffering, and of course, private practices and federally qualified health centers. I am very worried, especially, the loss of Medicaid for those 300,000 I've spoken about. Those are going to be concentrated in the populations that the health centers serve. So I do worry about the capacity to have enough revenue, especially guaranteed revenue, as opposed to relying on sort of being saved at the year end by supplementary budgets or things like that. I'm not sure yet how we're going to get around the issue and how we're going to support the health centers, but I do know that we will support. The state will support the health centers and figure out a way to keep them sustainable.
Thank you for that, Secretary Mahaniah. Not only that question answer, but really everything you shared with us today. We appreciate having you on today, and we look forward to our listeners joining us on Health or Consequences next month. Thank you again.
Thanks for inviting me. I am a not so secret fan of your podcast, so I really enjoyed being on with you.
Thank you.